Good morning, everyone. My name is Dr. David Brenin. I am the Chief of the Breast and Melanoma Surgical Services at UVA, and this morning I'm going to give a brief update on the use of focused ultrasound ablation for the treatment of tumors of the breast at the University of Virginia. I have the following disclosure to make. So before we talk about focused ultrasound ablation to treat tumors in the breast, let's just make sure we're all on the same page here. Focused ultrasound ablation, what is it? Focused ultrasound ablation is the use of high-intensity ultrasound energy, which is focused to induce localized tissue heating and disruption of the targeted lesion or tissue, which is at some depth underneath the skin. It's highly accurate and safe and causes minimum impact on the surrounding structures. This is a diagram of one of the focused ultrasound devices that we use to treat tumors in the breast at the University of Virginia. The treatment head of this device consists primarily of a HIFU transducer, depicted here, with an ultrasound imaging probe embedded in it. The ultrasound imaging probe is used to target or drive the device to the lesion, target, or tumor, and then the HIFU transducer is activated, producing high energy focused ultrasound waves that pass harmlessly through the skin and are focused within the tumor, heating it up and disrupting the targeted lesion. So this is a meeting about male breast cancer, and that's great because typically or often when I show this slide at a meeting about breast cancer in women, a lot of the women there, they have no idea what they're looking at, but we're men. So we probably, many of us at least, remember doing something like this, taking a magnifying glass outside on a sunny day and lighting things on fire, maybe some leaves, a piece of paper, or God forbid there are any beetles close by. But focused ultrasound ablation, when I think of it about it, is a little bit like this. You're taking the energy or the straight rays of the sun and focusing them at a focal point. And in that focal point, when you move the magnifying glass up and down and you get that focal point just right, it produces a lot of heat. When you think about it, if you took that magnifying glass and put your hand right on the surface of it, it didn't heat up your hand, but yet the rays of the sun were still hitting your hand. But if you moved your hand further away to the focal point, suddenly things begin to heat up. So why does that happen? And that's depicted here graphically. Here's the sun. The rays of the sun are essentially straight. They, have traveled millions of miles to get to your magnifying glass. And then the magnifying glass bends them slightly and has them intersect at the focal point where things heat up. So again, if you think about it, when you put your hand here, you didn't feel any heat, but yet the rays of the sun, the same rays were there. They're just passing through a very large circumference on your hand, but then they're concentrated, focused at the focal point where things heat up. And just to be clear, this is not what we're talking about, some kind of weird sunshine ablation or sunshine hair removal from the internet. So again, just to review, to kind of drive the point home here, we're not talking about the sunshine anymore, but when we do FUSA, we're talking about something like this. And this is the same diagram I showed you earlier, but blown up a little bit. This is from the treatment head of the Theracleon device. In more detail, this is a cooling jacket or membrane that is in contact with the skin, depicted here. This is the high energy HIFU transducer, and this is the ultrasound imaging probe that's embedded in it. We use that ultrasound imaging probe to drive the device and to find the target or tumor. And then once we have a good treatment plan and we're positioned well, we activate the high energy HIFU transducer, which produces high energy sound waves that pass through a large circumference of the skin, just like when your hand was sitting on the magnifying glass, it didn't get hot. And then those sound waves travel deeper in the tissue to a depth that we determine to the focal point, which is contained within the tumor. At that focal point, the tissue is heated up and physically disrupted. The energy passes harmlessly through the skin to the targeted lesion and heats up that targeted lesion. With each sonication, a sonication zone is produced. Here, that sonication zone is depicted from the side. As you can see, it's cigar-shaped, and we can control the size of these sonication zones to a certain degree. Typically, they're between 5 and 8 millimeters in height and 3 to 5 millimeters in width. It's a pretty small area. So in order to target a tumor, which is going to have a much higher volume than that, we need to put together a treatment plan. Again, here are those sonication zones depicting from the side. Right here is cigar-shaped, and here is that same sonication zone depicted from above, which would look like a circle. We create a treatment plan viewed from above here and viewed from the side here, and then we sonicate, producing a sonication zone. We then move the device to the next treatment target, sonicate again, producing another sonication zone, again depicted from the side here and from above here, and then we cobble together all of these treatments so that at the completion of the treatment, the entire volume within the treatment plan is sonicated and treated. So now that we all have a better understanding of what focused ultrasound ablation, or FUSA, is, let's move on to the main topic of my presentation: the use of focused ultrasound ablation for treatment of tumors in the breast at the University of Virginia. Our initial experience at the FDA made it clear that the best approach would be to proceed in a stepwise fashion, first treating benign tumors of the breast with focused ultrasound ablation, then moving to treat advanced stage breast cancer, and then finally to treat patients with early stage disease. Moving forward with this stepwise approach, we began by treating fibroadenomas. Fibroadenomas are one of the more common benign tumors of the breast, but they can be quite bothersome to patients, producing a mass in the breast, often causing significant pain and tenderness, and if large enough, they can change the contour of the breast. The typical management of these tumors consists of observation or surgical excision. While fibroadenomas are benign, many patients are quite bothered by them and wish to have them removed. At this time, the most common option is surgery, but transcutaneous ablation has obvious advantages, and at the risk of being too obvious, I'm going to explain them here. This slide has two photographs on it. In both cases, the patient's fibroadenoma is gone. One patient underwent surgery, the other a transcutaneous ablation. Now, no matter how good a surgeon I am, in order to do an operation, I'm going to need to make an incision. And that incision is going to result in a scar. There's nothing I can do to avoid that. So again, in both cases, the patient is no longer able to feel her fibroadenoma. She is no longer bothered by it. But in one case, there's a scar, and the other, there is no scar. And that's the most obvious advantage to transcutaneous ablation, not only to treat benign tumors of the breast, but also to treat all tumors of the breast, including malignancies. Since focused ultrasound ablation is completely non-invasive, it requires no local anesthesia, it's fast. The entire patient treatment experience is typically less than 2 to 2.5 hours, and recovery is quick, usually back to work the day after surgery. We've used the EchoPulse device for all of our breast cancer studies, and it consists of a computer-driven system comprised of an electronics cabinet, an extracorporeal probe mounted on an arm and moved by motors, a cooling unit, and an ultrasound imaging probe that is mounted within the HIFU transducer. Here is the business end of the device. This is the roboticized head. This is a cooling jacket through which cool liquid circulates to keep the skin cold during the treatment. This is the ultrasound probe that is embedded within the HIFU transducer. IDE G130-252 was the first study we did at UVA evaluating the use of focused ultrasound ablation to treat tumors in the breast. It was a single-arm study in which we enrolled 20 patients. The primary objective was to evaluate the feasibility of ultrasound-guided focused ultrasound ablation for the treatment of breast fibroadenomas. We evaluated both tumor response and the patient's experience of the treatment. The primary endpoints for this study were palpability of the lesion at 12 months by both the treating physician and patient, how well the patient tolerated the treatment and their satisfaction with the treatment, and change in tumor volume as measured by physical exam and under ultrasound. We made the above measurements at 3, 6, and 12 months following treatment. So how is the procedure carried out? The patient is first positioned comfortably on a stretcher, and intravenous conscious sedation is provided throughout the procedure as needed. The mass is then localized with standard ultrasound imaging, and degassed local anesthetic is injected around the tumor. The transducer head is then positioned over the lesion to allow for optimal imaging of the mass, and targeting and treatment planning is performed in multiple planes throughout the lesion. This is what the treatment plan looks like on the device. Here is the fibroadenoma as viewed in cross-section, and here are the sonication zones individually depicted from the side. The treatment head then moves to the next cross-section, and you can see that here. Again, the device suggests multiple sonication zones to treat that cross-section, and these are viewed from the side here. In the middle, we're viewing those sonications from above, and what this is depicting is the entire treatment plan, where we paint sonication zones across the entire tumor in 3 dimensions, thus treating the whole lesion. This is a complete treatment plan as viewed from above, with sonication zones painted across an entire lesion. During the procedure, there are alternating ablation and cooling cycles. Each sonication pulse lasts several seconds, followed by an adequate cooling time, which typically varies between 10 and 25 seconds. The pulse power is first adjusted to create boiling within the tissue in the sonication zone, and then once we determine the adequate pulse power, the treatment progresses until all the sonication sites in the treatment plan have been delivered. So what does it look like? Well, on the device, prior to treatment, the fibroadenoma looks like this. A sonication pulse is then delivered, and this results in a hypoechoic mark as depicted here following the sonication. The treatment head then moves to the next sonication site, and another pulse is given. This heats up the second area in the treatment plan. The device then moves to the third area in the treatment plan. Another sonication pulse is given, and this continues till all of the sites in the treatment plan are sonicated. Following treatment, the lesion usually looks like this. So this is typically what we saw. These are images from our first patient. On the left, you have the pre-treatment ultrasound image with the volume for the fibroadenoma being 1.53 cubic centimeters. 3 months later, after treatment, the volume was down to 0.47 cubic centimeters. That's a 69% reduction in volume. And as it turns out, that was typical for the 20 patients that we treated. And as you can see here, there's a mean percent reduction in volume at 12 months for the 20 patients in that trial of 68.9%. Based on our results, we concluded that focused ultrasound ablation was feasible and effective to treat patients with fibroadenomas. It carried minimal toxicity and was very well tolerated, and we then moved on to opening up a multi-center, multinational trial to treat patients with fibroadenomas with focused ultrasound ablation, in which we'll enroll a total of 100 patients. That study is nearly completed with greater than 95% of patients enrolled, and we hope to conclude that study shortly. Following conclusion of the study, we will move to submit that data to the FDA, which will hopefully result in approval of this treatment in the United States. Okay, so we had some good experience treating benign tumors of the breast. Now it's time to move forward with treating breast cancers at UVA. So I wanted to leverage everything we had going for us at UVA, namely that we have a fantastic multidisciplinary breast cancer program. We have an internationally prominent human immune therapy center headed up by Dr. Craig Slingloff, and we have our clinical focused ultrasound devices. I wanted to leverage all of this, so we decided we were going to move forward by treating breast cancer with a combination of focused ultrasound ablation and immune therapy at our program. Immune therapy leverages the patient's own immune system to help fight their cancer. An important component of immune therapy uses tumor-infiltrating lymphocytes. These are T cells, or a type of white blood cell, that are created by a patient's immune system and can help kill their cancer. In order to be able to do that, the tumor-infiltrating lymphocytes have to be able to traffic to or transport themselves to the tumor. Once they're at the tumor, they need to be able to infiltrate into the tumor and recognize the tumor as not self. The ability to recognize the tumor as not self, or an invader, is vital, because if the tumor infiltrating lymphocytes are not able to do that, they will not attack the tumor cells and kill them. Unfortunately, breast cancer has lots of tricks up its sleeve to fool these tumor infiltrating lymphocytes into thinking that the tumor is self. In other words, it's not an invader, it's not self. One of those tricks uses a protein called PD-L1. This protein normally tells a lymphocyte that a cell is self. Breast cancers can produce PD-L1 and convince tumor infiltrating lymphocytes that it's not cancer, but part of the patient's normal tissue. When PD-L1 is detected by tumor infiltrating lymphocytes, it tamps down the immune response. And for this reason, breast cancers that create PD-L1 fool the patient's immune system into thinking that it's not an invader and it should not kill the cancer. Additional ways that minimally immunogenic cancers can evade immune surveillance and confuse the patient's immune system into not being able to recognize a cancer and fight it include the ability to secrete type 1 interferon. This tamps down the immune response, similar to as I previously described. These tumors can also recruit what are called myeloid-derived suppressor cells and T regulatory cells. These are other types of white blood cells that again have the ability to confuse tumor infiltrating lymphocytes and tamp down that immune response and have the tumor infiltrating lymphocytes not fight the cancer. And then, as I mentioned previously, through the expression of programmed cell death ligand PD-1, which again downregulates the CD8 positive T cells' ability to fight the cancer. Here's a cartoon showing a very tricky breast cancer cell, and unfortunately this is commonly the case. That breast cancer cell is here, and it not only has an antigen for a tumor cell on its surface, but it also makes that antigen PD-L1. Remember, PD-L1 convinces attacking tumor infiltrating lymphocytes, as depicted here, that the tumor isn't a tumor at all, but that it's normal tissue. It's telling this T cell, well, you may have gotten here, you may have detected that something's wrong, but there's really nothing wrong. Just move along. Leave me alone. The way anti-PD-L drugs work is that it blocks that PD-L1 tumor, not allowing it to tell the T cell to leave it alone, resulting in the T cell killing the cancer. Immune therapy has been a real game changer lately and has been very effective to treat patients who have highly immunogenic tumors such as melanoma, lung cancer, and kidney cancer, but has only shown minimal results for tumors that are not very immunogenic like breast cancer, pancreatic cancer, and colon and rectal tumors. We hope that we can treat minimally immunogenic tumors with focused ultrasound ablation and make them more immunogenic. For our first study of focused ultrasound ablation to treat breast cancer at the University of Virginia, we combined focused ultrasound ablation with a drug called pembrolizumab. Pembrolizumab is a programmed cell death 1 inhibitor and has been shown to be effective against treatment of some triple-negative breast cancers, which tend to be more immunogenic, but pembrolizumab is not effective against estrogen receptor positive tumors, which tend to fly under the radar of the patient's immune system. That brings us to our first study at the University of Virginia to treat breast cancer with focused ultrasound ablation, namely breast 48, which utilized focused ultrasound ablation plus the drug I just mentioned, pembrolizumab, to treat patients with stage 4 breast cancer. The idea behind this is that we know that focused ultrasound ablation can cause an acute thermal injury to the tumor and initiate a brisk local immune response. As part of that immune response, CD8 positive T cells would then traffic to and infiltrate into the damaged area of the tumor, and then we could give pembrolizumab, which could upregulate that local cellular immune response, hopefully resulting in a brisk systemic response as well. The primary objectives of breast 48 were to assess the adverse event profile of pembrolizumab and focused ultrasound ablation therapy in patients with metastatic stage 4 breast cancer, and to determine whether the addition of pembrolizumab to focused ultrasound ablation increases the proportion of CD8 positive tumor infiltrating lymphocytes into the primary and periablative zone. Stated more simply, the concept behind breast 48 was as follows. We know that pembrolizumab is able to induce an immune response in some breast tumors, but not most. We also know that focused ultrasound ablation is able to induce an immune response in most tumors, but that local immune response is typically not enough on its own to be curative. And what we were testing was the idea that might the combination of focused ultrasound ablation and pembrolizumab be more effective. This is the schema for that trial, breast 48. In the first arm, or arm A, patients got pembrolizumab after the focused ultrasound ablation, and in arm B, patients got the pembrolizumab prior to focused ultrasound ablation. So like I said, patients to be included in this trial had advanced or stage 4 breast cancer, as well as the other inclusion criteria on this slide. Here are ultrasound images from one of the first breast cancers that we treated. Here's the tumor within the breast. Here's a clip as seen on ultrasound within the cancer. Here is an image from the treatment plan, and as you can see, we delivered focused ultrasound ablation pulses to only within the tumor. We did not treat any of the surrounding tissue. 22 days after the ablation, we biopsied tissue in the periablation zone and tissue from within the ablated region of the tumor. This very busy slide shows a series of photomicrographs. In this column, this is before treatment within the tumor. This is at day 22 in the area of the tumor that we ablated, and this is at day 22 in the periablative zone, in this case still within the tumor itself. They show an increase in the number of CD8 positive T cells that infiltrated into the tumor as compared to pre-treatment, as well as an upregulation of PD-L1 within the tumor, again as compared to pre-treatment. Breast 48 is now completed and closed to accrual, and the final data from that study is currently being analyzed. However, the preliminary data was intriguing, and we've now come to the point where it's time to open a study looking at focused ultrasound ablation to treat patients with early stage breast cancer. Early analysis of the data from breast 48 indicated that focused ultrasound ablation and pembrolizumab was able to change a patient's immune response to breast cancer. Preliminary results demonstrated an altered tumor microenvironment in which there was an increase in anti-tumor T lymphocytes, both CD4 and CD8 positive, trafficking to and intercalating into the tumor. These T lymphocytes are strongly associated typically with an increase in the immune response. However, we also found that shortly after upregulating that immune response with the T cells, myeloid-derived suppressor cells also traffic to the tumor. The problem with this is that myeloid-derived suppressor cells tend to tamp down an immune response. So we were quite disappointed in this because as soon as the T lymphocytes upregulated the immune response, the myeloid-derived suppressor cells tended to tamp it down. So the tumor was still able to work its magic at running below the radar of the immune system. In addition, mouse models in the Price lab from studies that were done concurrently with breast 48 demonstrated similar findings. So after demonstrating that focused ultrasound ablation could initiate a localized immune response in patients with stage 4 breast cancer, we began developing a trial to treat patients with earlier stage breast cancer. That trial is Breast 54, and Patrick Dillon is the PI on this study. In this study, we use focused ultrasound ablation in combination with low-dose gemcitabine to augment the immune control of early stage breast cancer. So why use gemcitabine? Gemcitabine is a drug that is used to treat breast cancer, but its effect on the tumor is modest. However, in preclinical findings in the Price lab at UVA in mouse models, gemcitabine has been shown to decrease circulating myeloid-derived suppressor cells. And as you recall from my earlier comments, breast 48, that myeloid-derived suppressor cells traffic to the tumor after we perform focused ultrasound ablation and tamp down that immune response. What we hope to do in Breast 54 is pre-treat patients with gemcitabine, drive down the myeloid-derived suppressor cells, and then initiate an immune response in the patient's tumor with focused ultrasound ablation. And as the myeloid-derived suppressor cells can't traffic to the tumor, we hope to initiate a much more robust and durable response. Here's one quick slide from Dr. Shabani's work in the Price lab, which demonstrated that focused ultrasound ablation plus gemcitabine was more effective than gemcitabine alone or focused ultrasound alone at controlling both the primary tumor and lung metastasis in their model. The study Breast 54 will have 3 arms. In Arm A, patients will receive gemcitabine alone. In Arm B, they will undergo focused ultrasound alone. And in Arm C, they will receive a combination of gemcitabine and focused ultrasound, with the gemcitabine being given first. After those treatments, all the patients will have the standard of care therapy, which will include sentinel lymph node biopsy, definitive surgery, and will collect tissue from the tumor at various stages. After their surgical treatment, they'll receive standard adjuvant therapy and be followed for 5 years, and will collect data over the entire time period. So for clarity, in Breast 54, there'll be 3 arms. In Arm A, patients will receive gemcitabine alone. In Arm B, patients will undergo focused ultrasound ablation alone. And in Arm C, they'll receive a combination of the two. Patients will be randomized 1:1:1 with a total of 48 subjects, and that means 16 patients in each arm. As Breast 54 is an exploratory study, we'll be looking at the primary endpoints of safety of focused ultrasound ablation, safety of gemcitabine alone, as well as the combination of the two. And we'll be looking at the following primary endpoints: adverse events, time to surgery, and positive margin rate. There are multiple secondary objectives and endpoints, but they are too numerous to review due to the time constraints of this presentation. However, they are presented on this slide as well as the next. Patients that will be included in this study have early stage breast cancer, in other words, clinical stage 1 to 3 breast cancer. Their tumor can be of any receptor status, and if genomic profiling is performed, they should be at high risk. However, genomic profiling is not required in order to be entered into the study. For safety in Breast 54, tumors must be at least 5 millimeters from the skin, and the rib to treatment target zone must measure greater than 1 centimeter. Again, we're only treating inside the tumor, and more specifically, the goal is not to treat the entire tumor, certainly no more than 50% of it. Here is a picture of the first specimen from a patient that we treated. This is after treatment, after the tumor has been excised, and you can see there is a necrotic portion of this tumor where we provided focused ultrasound ablation juxtaposed to viable tumor. And again, this is our intent. We're going to obtain biopsies for evaluation of the necrotic area and of this transition area, as well as of the viable tumor. Breast 54 is ongoing. It opened earlier this year. There are 3 patients who have been enrolled to date, and we soon hope to receive an updated device from Theracleon, which will allow us to treat patients with smaller tumors so that we can increase enrollment rapidly. So to wrap things up, at the University of Virginia, we have utilized a stepwise fashion to evaluate the use of focused ultrasound ablation to treat tumors in the breast. We started by treating benign tumors, namely fibroadenomas. We then moved on to treating patients with advanced stage 4 breast cancer with breast 48. And now we're on to our study called Breast 54, in which we're evaluating the use of gemcitabine and focused ultrasound ablation to treat patients with early stage breast cancer. We strongly believe that focused ultrasound ablation has the potential to be both a local and systemic therapy, and we will be leveraging that concept in current trials at the University of Virginia, which use focused ultrasound ablation in combination with immune therapy for patients who otherwise would have a very low likelihood of response to immune therapy alone. Finally, I'd like to thank the following organizations and individuals without whom we couldn't make this happen. Thank you for your attention.